to the poets and the perfectionists, the warriors and the worriers, the timely and the timeless. We're Care First Blue Cross Blue Shield, and we're transforming healthcare for the future, for today, for the communities we serve. This is our pledge to you.
These are the moments we live for.
Good morning. Thank you, DC Chamber, for allowing me the honor of introducing the remarkable panelists for our State of DC Health panel, sponsored by Care First Blue Cross Blue Shield. My name is Dr. Gingy Lindsay, and I serve as the Director of Public Health at Care First. Public health is a new function within our organization and not a common function that you will find in most health plans. But the mission of public health, to protect and improve the health of people and their communities, is directly aligned with the mission of Care First. In applying a public health framework to our business as a health insurer, we have two main functions. The first is to be a proactive partner in our regional public health systems, whether that be in coordinating responses to public health threats like COVID, or aligning our efforts to address challenging population health issues like inequities and maternal health outcomes. Our second role is to support Care First in developing data-driven approaches to achieve racial health equity. This means using a health equity lens to examine and understand our population health outcomes and applying those insights to implement strategies as a payer that will help our residents in achieving their optimal health. I look forward to today's panel discussion, which well aligns with Care First's commitment to addressing and advancing health equity. And now it is with great pleasure that I will introduce the moderator and panelists for this morning's discussion. Our moderator today is Brian Pinnock. Since 2018, Mr. Pinnock has served as the President and CEO of Care First. Prior to this role, Mr. Pinnock was Care First's Chief Operating Officer with responsibility for the organization's 4 strategic business units and technology and operational support services. Before joining Care First, Mr. Pinnock was a member of Aetna's executive team, where he held key leadership positions during a 19-year tenure. The Honorable Vincent Gray has been a tireless advocate for the residents of the District of Columbia, serving in both city government and the nonprofit sector for more than 30 years. This includes championing disability rights with the ARC of DC, Director of the DC Department of Human Services, and the founding Executive Director of Covenant House Washington. Councilmember Gray's dedication to the residents of Ward 7 inspired him to seek elected office, winning his bid as Ward 7's council member in 2004, then going on to become the chairman of the DC Council in 2006 and the 6th elected mayor of the District of Columbia in 2011. In 2016, Councilmember Gray returned to DC Council to represent Ward 7, where he also serves as chair of the Committee on Health. Dr. Anita Arno is the director of the Office of Health Equity at DC Health. She is an experienced public health professional with a track record in the field of health equity. This includes work promoting community collaboration to transform views and perspectives related to the root causes of health disparities, the integration of health equity concepts into healthcare delivery systems, and racial equity through a public health lens. Dr. Arno held previous leadership roles with the City of Kansas City, Missouri Health Department, Louisville, Kentucky Metro Department of Public Health and Wellness, and the University of Louisville School of Public Health and Information Sciences. Next, we have Mila Kaufman, who since 2011 has served as the Executive Director of the DC Health Benefit Exchange Authority. Prior to her appointment, Ms. Kaufman was on the faculty of the Georgetown University Health Policy Institute as Research Professor and Project Director, where she advised state and federal officials on ACA implementation. From 2008 to May 2011, she served as a Superintendent of Insurance in Maine. Ms. Kaufman is a nationally recognized expert on private health insurance markets and state and federal regulation. Last but certainly not least, we have Jacqueline Bowens, who is the President and Chief Executive Officer of the DC Hospital Association and member of the association's Board of Directors. In her role as President and CEO of DCHA, Ms. Bowens represents 15 member hospitals, which include acute care, behavioral health, rehabilitation, and pediatric facilities. Ms. Bowens has had a long history in hospitals and healthcare, and prior to joining DCHA, served as the Chief Executive Officer of the DC Primary Care Association and the Executive Vice President and Chief Government and External Affairs Officer at Children's National Health System in Washington, DC. And with that, I will turn the program over to Brian. Thank you all so much, and good morning.
Thank you, Dr. Lindsay, and good morning, everyone. As Dr. Lindsay mentioned, CareFirst is pleased to sponsor the State of DC Health Panel, and I'm personally honored to again have the opportunity to moderate what I believe will be a timely and impactful discussion today. During previous DC Chamber events, we've discussed the challenges that stand between our shared vision for a more equitable, accessible, and affordable healthcare system. We've also highlighted numerous efforts locally and even nationally working to address structural and social determinants of health. Today's discussion will dig deeper and move us toward necessary action as we explore our focal theme, creating a culture of health equity, driving accountability for the District of Columbia. I'm eager to moderate our esteemed panel as we discuss how to think differently and get us closer to meeting our shared goal of advancing health equity. So with that, let's kick off what I know will be an enlightening and robust conversation. I wanted to start with at least an overarching theme, and I think an acknowledgement that appropriately there is a great deal of attention right now on social determinants of health and upstream environmental factors that influence our health. We know that a focus on these determinants will ultimately lead to healthier communities, but as we peel back the layers that make up the structural and societal determinants of health, we quickly see a complicated web of factors that drive health inequities in our communities. So I thought, Dr. Arno, you led the DC Health Office of Health Equity's DC Health Equity Summit. Could you share thoughts from that summit on the evolution of the district's efforts to address health disparities from where we are at the beginning of the pandemic and where we've come, and as our posture at the height of the pandemic, how that's evolved and progressed to where we are today? Dr. Arno,
Thank you, Brian. Thank you all for having me today, and I'm delighted to be on this very esteemed panel. There is no doubt that we have come a long way. Prior to the pandemic in 2019, the district published its first health equity report, which laid out a framework thinking about 9 key drivers of health, and it moved the conversation from just, and I'm glad you mentioned it, not just social determinants, but the structural determinants of health. And those 9 key drivers included education, employment, income, transportation, housing, the outdoor environment, and community safety, to name but a few. And so when the pandemic hit, number one, none of us knew what it was. But as a city, one of the things we first recognized was that we had to come together. And so the mayor correctly put a team together to talk about reopening DC. We shut down in a hurry long before we knew what really the pandemic was and what was driving it. But we soon learned during that process that we still needed what we call essential workers. Most of us had the opportunity to work from home, but a lot of us had to be out there keeping the city going. And in that, there was this we were in a situation where we didn't know, but we had to learn fast. And so we also worked with folks like the Hospital Association, but also social services. You know, everybody had a part to play. So what we learned during the pandemic, we had 3 different waves. We were learning in, but by the time we got to having actual vaccines, you know, first we had to prioritize because of limited resources, and we focused on the older adults in our community. But we've seen shifts in terms of who was impacted, how they were impacted, including race and ethnicity in the 3 waves. So in the first wave, we saw the Hispanic population and the corridor, the 14th Street corridor saw a rapid transformation. One of the good things that we had started prior to the pandemic was drilling down to what we call the statistical neighborhoods. So we were not only able to say which wards, but we could actually see in very small areas where that growth was. So it was all of those things. So when we came to having the summit, which we held on December 9th, 2021, we weren't out of the pandemic. Of course, Omicron came and we were still going, it was still taking much longer than we anticipated. But we thought it was a time for us to think about building a roadmap to a just post-pandemic future. And so while DC Health had published the Coronavirus Health and Healthcare Recovery Report in May 2021, by December, we needed to think about the other pieces that were so critical. And that was the social and structural determinants of health, as well as structural and institutional racism. So that was the kind of arc of how things evolved. But I think when the mayor launched the Reopen DC process, that 9-key driver, multi-sectoral, public, private, nonprofit, all of us working together was critical in setting us up for some kind of success and being mindful in particular about equity and ensuring that we responded in this whole of community response. So that's really what we talked about. We recognized that and we came out with 6 recommendations at the end of the summit, which really focused a lot about what did we learn during the pandemic and what are the key ideas that we need to take forward. And the critical one of those is that we need to continue the collaboration, deepen our integration, and think about how we move all of this together. One of the indicators that we can think about, we know, for example, we've seen, in fact, poverty across the nation fall surprisingly during the pandemic, but it's largely because of the things that we actually invested as a nation and as a city to make those things happen. But with that, I'll let you go on to the next question.
Dr. Arno, no, I appreciate it. It sets the stage perfectly. I think that frame, that perspective of what we experienced, and obviously there was no playbook, a lot of humility throughout that process as we learned and better understood what the data was telling us. And I think that's a great jump off. And Mila, I'd love to get your perspective. The district has one of the lowest uninsured rates in the country, but still experiencing vast disparities in access to care. And so these two things coexist. That's what the data tells us. With chronic conditions in mind, can you share how we strike a better balance between addressing immediate issues while also tackling social determinants that are going to have immense long-term impact on the state of health?
Yeah, and thank you, Brian, for your leadership at Care First, working on not only health disparities, but health equity. It's great to have you as our partner. And I just want to say thank you to Angela for hosting this terrific event. So we have to do both, right? It's not a choice. We have to work on short-term interventions and solutions, and we have to work on long-term. So when we embarked on our journey, we wanted to supplement the great work that Dr. Arno and other city officials are doing, the great work that the private sector is doing in the area of health disparities and health equity. And in fact, when we first started, Councilmember Gray asked us to take a look at east of the river and work with our health plans to see what on the private side can be done. And that work led us to us establishing a broader review of what can we do with our health plans that impacts the entire city and the population we serve. And you might be asking, well, what's the Affordable Care Act online health insurance marketplace, DC HealthLink? What can we do? Well, we can do a lot, and we know we can't solve for housing insecurity or food insecurity or some of the other critical factors, but we could change how we do business with health insurance and coverage books. So, for example, we know that cost is a major barrier to accessing care. So we worked with our health plans, and we decided we're going to change our coverage design, our standard plans, to start eliminating cost as a barrier for conditions that disproportionately impact communities of color. So starting January 1, type 2 diabetes is going to be covered at no cost to the patient. Foot exams, eye exams, blood works, the care that you need. And of course, insulin is already covered at no cost. But those are the kinds of interventions that we need to engage in the short term. And I'll just mention another important area. We can't ignore bias in medical care. And you can be the wealthiest Black woman in DC, and you can experience discrimination and bias in the care you receive. And that has obviously nothing to do with your economic status or where you live. It purely is because of the color of your skin. So we are looking at bias to see what we can do together with our health plans to start tackling that. And I'll just give you an example of how bias plays out. A patient went to the ER, Black patient, and instead of being treated for a severe episode of sickle cell, the patient was treated for a drug overdose. And that did not go over well, right? That patient barely survived. So bias is a very real thing. And it needs to be addressed both in the short term and in the long term in how we view tackling health disparities and getting us all to health equity.
Yeah, Mila, I so appreciate that. And I think what I take away from your comments and Dr. Arno's is really looking at this from all sides, that the definition of healthcare is expanding, it's changing. And I think we're getting to a more precise understanding of what drives state of health through time and circumstance and what real intervention looks like and management of health looks like. But also to your point, seeing with a fresh set of eyes the reality of what treatment of health conditions looks like and a better understanding of how to address biases that have and have clearly existed in the healthcare system really since the dawn of healthcare. I want to pivot on that a bit and really explore this idea of increasing affordable housing and addressing food insecurity. You mentioned it, Mila, that may not be the domain of the health benefits exchange, but it's certainly a part of what drives sustained health, quality of life. And Councilmember Gray, you've been a tireless advocate, and as Dr. Lindsay noted, and as I'll repeat, at the forefront of many of these efforts of really thinking differently about systems and structures around people that influence and affect health. How do we maintain the political will and momentum necessary to implement solutions needed to address the systemic drivers of health inequities that have the ability to change the trajectory for generations to come, not just treat illness, but change the trajectory of health?
Thank you, Brian. I appreciate so much of the chamber, Angela, and all the folks who are here today being a part of this effort. And I appreciate the chamber's work to continue to keep these issues in the forefront. I'm really excited about where we're going at this point. I'm going to talk about Dr. Arno and talk about Mila and also my dear friend from the chamber, from the Health Hospital Association. We really have never had a healthcare system in the District of Columbia that spanned the entire city. It's been ludicrous to see what has happened with people in the District of Columbia, Brian. And so we are now creating a real healthcare system that will be able to reach everybody who lives in the District of Columbia. We have not had a real hospital system, which is unbelievable, but it is true. But we are now creating a real hospital system and creating urgent care centers also that will be a way of providing services to people that otherwise wouldn't be provided to them. We are in the course, Brian, and you know this, we're in the course of building a hospital on the east end of the city. We've had we haven't had urgent care centers, let's put it that way. We've had the United Medical Center, which really has not been a place where people could go and feel comfortable with the services that they're getting. that is going to change with the new hospital that we're building. It's going to be on the campus of St. Elizabeth's, and I am delighted with the services that are going to be provided there, along with the urgent care system that we're building at the same time. So when I look at what Mila is doing, and I'm delighted to have been involved in helping to bring Mila on board, and I'm glad that she's still working for the work that she's doing, and also with Dr. Arno and others who are involved with the services here in the District of Columbia. We will, when we open our hospital, which will be another year and a half, 2 years, it's going to be an absolutely wonderful place for people to feel comfortable going, Brian. And I'm going to be delighted the day that we cut the ribbon on that, and have all the accoutrements that are necessary to be able to make it feel a place that people can feel comfortable going to. We had Providence at one point, which is now closed. That was in Northeast, and also served people in areas of the East End. But now we're going to be able to traverse that and be able to get to a different place than we've had before. So I want to thank my dear friend, also Jackie Bowens, who went to Los Angeles with us to look at what we needed to do there, and we learned a lot in going with Los Angeles and working with the leadership there, and we brought back a lot of what we've learned. And I'm so excited to say that I find myself just going on about this. So thank you, Brian, for this. I'm glad that we have a chance to be able to talk about these services, and I'm hopeful that we will, keep the trajectory in front of us that will make sure that healthcare services are going to be available to everybody in the District of Columbia, not just certain populations, but everybody in the District of Columbia, especially those who live on the East End and may not be as well heeled as others may be. So thank you, Brian.
Yeah, council member, I always appreciate your ability to really give voice to the whole picture. And Mila did this at the outset of her conversation. She talked about we can have low uninsured rates and still have inequity and still have access challenges. And council member, you've certainly been at the forefront, not just of the conversation, that we can have world-class healthcare in the district, and we do, and also have substantial systemic gaps that don't meet the basic needs of local communities. And you've been a champion, not just for helping to educate around that reality, but also doing the work necessary to build that better system. And so I want to turn it over to your friend, Jackie Bowens, and ask, Jacqueline, from your perspective, as we look more deeply at specific policy action, how is the passage of legislation establishing the High Need Healthcare Careers Scholarships and Supports Program important to the overall discussion of addressing health equity in the district and efforts to ensure we have a healthcare workforce that is diverse and can tackle the underlying morbidities and disparities we're seeing?
Brian, thank you. And thank you to the Chamber for this opportunity and the opportunity to be with these esteemed panelists. And, I don't know why I get to follow Chairman Gray. That's a hard act to follow. But certainly the chairman has really set the stage, I think, and even in his remarks and this whole commitment to equity and the alignment of equity and making sure that we have an adequate workforce. Because at the end of the day, we are all about patient quality, and you can't have good quality if you don't have equity. And we clearly know that the data tells us that we need to, when we're looking at populations, particularly underserved populations, is critically important that those populations are served by people that look like them. And so the idea of making those investments, particularly in creating opportunities around legislation, is important. And the legislation certainly, I believe, is a critical first step, and anything that we can do in terms of broadening opportunities and access and eliminating barriers and support to help people of color to have jobs, particularly careers in healthcare, is critically important. I'm extremely proud of the work that we are doing in our space with the hospitals. We, again, working in collaboration with many of the panelists here, but also just hearing the voice of the chairman and how important this issue has long been to him. We have created a framework around diversity, equity, and inclusion. And that framework has not only been focused on the patients, rightly so, but also looking at our workforce and what steps and efforts that we need to do in terms of issues around mitigating bias, eliminating barriers, creating new opportunities for entry, simplifying. And one of the things we've also been working on is recognizing that the hospitals are a part of the industry, and how do we work together and bring our entire industry together of employers to begin to think about how we can do a better job. We've been working very, very closely with the DC Department of Health, the Department of Employment Services, the Workforce Investment Council, and we've brought employers together to really begin to rethink and imagine how we can really align the needs of our industry together with making opportunities and creating opportunities for the community, really targeted toward DC residents, particularly those in Ward 7 and 8. So we really do recognize there is a village of opportunities and careers in healthcare. We have to really elevate that awareness and understanding of what those jobs are. Yes, working in the clinical fields of doctors and nurses are critically important, but there's so many other jobs and opportunities in healthcare that exist. And so that idea of lifting awareness, creating pipelines, starting early and often, working in collaborative partnerships and expanding those opportunities. You know, I'm very, very pleased that workforce is a #1 priority for our industry. I've been told and told and told again the importance of that work. And one of those key priorities also happens to be, how do we make sure that the individuals in our organization that are there to meet the needs of our patients look like the patients that they serve. And equity is an essential, critical part of that, because if quality is the #1 thing we care about, we cannot have quality if we don't have equity.
Yeah, Jacqueline, one of the things that's always impressed me every time I hear you talk on this topic and others is you think about this as an ecosystem approach, and both in terms of the opportunities and challenges that exist in healthcare, but also in equity, and the importance of each participant in the ecosystem doing what it's capable of doing in collaboration. And I think that spirit is so incredibly important as we try to drive more systemic progress going forward. And so I thought we could pivot, Mila, and perhaps you'd like to build on that a bit in terms of where progress can and is being made. So not just opportunities, but where we think we've actually got some traction, and what are some examples of where you've seen progress being made?
And thank you for that. So I want to specifically talk about progress where we've identified embedded structural institutionalized bias or discrimination. And I'm going to give you 3 examples, and then I'm going to challenge all employers to help us with this. So the structural embedded bias is really visible in clinical guidelines and standards. And it's visible because actually race is used to in the tools. And so, for example, GFR is a test that measures how well your kidneys function. And until recently, that test had a race adjustment. So if you are a Black patient, your score got artificially inflated. And it made it look like your kidneys functioned better than they did. And so Black patients received delayed care. sometimes didn't qualify for kidney transplants in a timely way because of that. Now that changed, but that's a great example of structural bias and racism that exists. And there are lots of clinical guidelines that still use race to the detriment of Black and Brown communities. So Black and Brown patients have worse health outcomes as a result of the clinical guideline that's used. So great, GFR changed. That's great. But there's so many that haven't. A good example is the little device that measures your blood oxygen level. That device that everyone uses, that we all learned about during COVID, is calibrated for white skin. So if you have pigment in your skin, if you're a Black or brown patient, you're not going to get an accurate reading, and you might be really sick. And as a result, you may not get the intervention you need. That's another example of a structural bias that's embedded in even the instruments that our medical professionals use. That hasn't changed, although the FDA established a working group to look at that. In Europe, it has. So if you live in Europe, you're not suffering this kind of embedded discrimination. So that's where I see hope also. And this is a challenge for the employer community to help us look at in clinical guidelines. If you are self-insuring your benefits, get your experts to look at bias and weigh in with national standard-setting bodies. If you buy health insurance, ask your insurers to take a look at these biases and weigh in. Use the chambers, use your advocates, associations to influence that national dialogue. Now, some medical entities have started to review their clinical guidelines, others haven't, and there's a lot of racism and bias built in. So that's a great opportunity for everyone to get engaged and demand change.
Yeah, Mila, I think listening to that, and I think this is a great connection next for Dr. Arno. The approach here from a healthcare perspective is for equity to be applied across all aspects of what we do, right? Each point in the process from a healthcare perspective, getting after the bias that exists in systems and structures. I would say, Dr. Arno, this is complementary to thinking that I know that you've been leading around this concept of health in all policies framework, a health equity lens and a perspective that may be traditionally overlooked as we think about impacts to health and well-being. Can you give us some examples of that, areas that you think as we have this discussion about what it looks like for equity to show up in all aspects of healthcare and for health to show up in all aspects of policy? What are some of the specific areas that you think we need to most urgently target?
Right. Well, I gleaned, or I hinted at it at the beginning when I talked about the 9 key drivers of health. Because we know the data shows us that only 20%, 10 to 20% of what drives our health outcomes that even get us to the doctor's office, et cetera, has nothing to do with healthcare. So the other 80% are those other things. So we need to invest in and think about all of those other things that positively promotes good health and good opportunities for health. So we have even things like we're now talking with the chamber, for example. Most of what the chamber does is not narrowly focused on health, although it's a critical part of our economy. But all of the other partners who are participants at the chamber are producing our economy, paying the wages of folks who live in the district, providing health insurance, which was what Mila was referring to, bias in terms of how we hire and fire, and do we have equity built into all of the things that we do in the district. So even in public health, we also have to do more work. We know we can't do it alone, and public health care can't do it alone. So Jackie talked about workforce. So we also have a public health workforce crisis going on. We've lost folks along the way because of what happened in the pandemic. So we also have to think about that. Lots of folks who work in public health may not be traditionally trained in public health, but they come from all sectors of our community. So at our summit, we had, beyond the 9 key drivers, we have a lot of institutional partners who are critical. So Angela, president of the chamber, was here. We had academic institutions here because they train people. They are major community residents. They are employers. So all across the board. So everybody has a role to play. And one of the things that the DC Health will be leading with, we're about to launch a steering committee, a new steering committee for our Healthy DC 2030 process. Up until now, we've had a very collaborative process. It has tended to engage all of the sectors. But when we introduce our new steering committee, it will actually reflect not only the healthcare perspective, but all of the other 9 key drivers. And so we are going to have that as a sustained process of engaging people more directly in underscoring the importance of thinking about health, not just as healthcare, because health insurance is important. And Mila talked about the fact that, yes, we have high rates of insurance, but people need income and wealth and housing and transportation and all of those other things to live a high, viable quality of life, which is what I know Council Member Gray is really, really contributed to when he was mayor, in his current role, and all of the other things. It's really about promoting a strong quality of life for every single district resident. And it means that we need to invest in all corners of our district and make sure that everybody has high opportunities for health. The data that we produced in our health equity report showed, for example, there was a 21-year difference in life expectancy at birth, which is just shocking in a very small space that is the district. So I think those are the things that should drive us. The evidence that came out of the pandemic of what can happen, we actually improved or decreased the rate of poverty during the pandemic. And a lot of that, I think it's a really important thing to think about, because we thought about kids who were at home and not going to school. We talked about connectivity and all of the other things that are barriers even to learning, which has a long-term impact on people's ability to get jobs, hold jobs, work from home, and all of the things that were interconnected along the way.
Well, Chairman Gray, Dr. Arno teed it up perfectly, framing a broad policy view. But as we look more immediately, so what's on the near horizon, what legislative actions do you see in the pipeline for 2023 that will help to address some of the root causes of health inequities? What do you see as the opportunity immediately in front of us, Chairman?
Well, thank you very much, Brian. We have a number of initiatives that are in the forefront that we're moving forward with, including trying to figure out how we address the food justice issues in the District of Columbia, which plague so many people. I am delighted that just in recent days we opened a new grocery store, Lidl, in Ward 7 that will serve a lot of people now who have not been served at all well in the past. I'm delighted that we've got those opportunities that are opening up for us, and those legislative opportunities are one that part of a bill that I actually introduced and have championed as best as I possibly can to move forward in the near future. We've got work that we're doing in Penn Branch, which is another major area of Ward 7, and we're working closely with our friends in Ward 8 also to be able to bring these additional opportunities, to them as well. So I'm delighted with the progress that we're making, Brian, in terms of what we can do, and we've got a lot more work to do. We can't rest on our laurels about opening a couple of grocery stores. We got a new Giant that's opening. We got another opportunity that we're opening in areas of Ward 7. So all of those are going to be great opportunities for the people to do things and have justice brought to them that they haven't had available to them in the near past. So I'm going to say that I'm delighted with progress. I know we got a lot more progress to make, and we will be, happy to, with our friends at the chamber, who by the way have been very, very helpful to us in being able to move forward with. So, Angela, thank you and your colleagues for working closely with us to make some of these opportunities available. It's just incredible that we have, pockets of the city that have such, amenities available to people, and then other areas of the city where those amenities don't exist at all. And that's what a part of what we're trying to create now, Brian, to be able to create a different experience for people in the District of Columbia. And we're going to continue to do that as effectively as we possibly can.
Yeah, Council Member, it brings me back to a prior conversation that you had during one of these panels. As we talked about the importance of not losing the moment, the opportunity that existed, that was created by the pandemic, a lot of challenge and hardship, but also increased awareness of the systemic issues that need to be addressed, and what a better reality needed to look like as we transition through that time. And it's great to see not just the momentum continued, but really increasing, and that we're getting after these issues, not just on the public sector side through policy, but also through private sector collaboration. So we appreciate your continued leadership there. And in the spirit of collaboration, and you've heard it throughout this discussion so far this morning from each of our panelists, there's been a resurgence in energy around the potential for public-private partnerships, with greater recognition that community partnership is essential to addressing the root causes behind inequities. This is encouraging, but the COVID-19 pandemic also underscored the great distrust that many marginalized groups have of established systems, organizations, clinicians, and even public health resources. And Jackie, I was hoping we could come back to you. I know this has been something that you've spoken on and advocated for in the past. From your vantage point, how can we work to improve community relations and establish a greater sense of trust and collaboration that we can use to catalyze even more progress?
Yeah, thanks, Brian. I mean, you're absolutely correct. I mean, the idea and the recognition that we've had structural racism in our systems of care, and Mila and Dr. Arnault spoke to this as well. I mean, those are the realities that we've lived with, and certainly there have been attempts to address that. And while I believe that those have been well intentioned, we've missed the mark. And certainly COVID was an awakening for many of us, as I noted before. Our association, that focus and attention has been elevated, and it is something that is and remains a priority for us. And my message has been that we've got to be consistent in terms of our focus and our energy. We have to be transparent, and we have to be engaged, and it can't be part-time. We cannot, do these things when, emergency crises arise, because we're talking about people's lives. And if we are really serious about trying to really make a change and build that trust, trust is not incidental and temporary. If we really are serious about that engagement with our community, they have to truly see us as a partner, see us beyond these four walls. And that means we have to always be there. We have to recognize when there are opportunities, when we can lead, when there are opportunities for us to collaborate, and when there are opportunities for us to support and help our communities understand that. How do we invite our communities in to our organizations, but also how are we out there often present and make sure that there is recognition among our staff, as well as our patients, in terms of the importance of representation, recognition, and engagement. And so we are really working collaboratively with our members, with our community in that regard, and really trying to really send forward the message of the importance of engagement and being a resource and being available. One of the things that we've also been working on is trying to find as many opportunities as possible to ensure that our boards, our leadership, our staff really are reflective of the community. We've been working with trying to find opportunities with many of our small businesses, particularly, we do a lot of purchasing, but there may be opportunities for small businesses. And so we're encouraging many of our hospitals and others to look around your community and find those opportunities for many of our small businesses, break down those barriers to entry. So the more that our community sees us as a member of their community and not just this business that's there, that's important. But breaking down those barriers for entry, finding more and more opportunities to partner, and understanding what our community needs, work as Dr. Arnaud talked about, hearing their voices. It's not for us to tell our community what they need. Is for them to tell us. And so really trying to really rethink and reevaluate what those relationships look like. But most importantly, as I said, being consistent, being transparent, and being engaged, and keeping that always and often, I think is really, really important. And being very, very important in terms of sharing information and letting people really see in a simplified way where those investments are going and how things are different. So those are some of the things that we've been looking at. And I'm really pleased that I am really beginning to see some differences in terms of perceptions and trust, but consistency, I think, is really critical.
Jackie, you hit on a number of, I think, really critical elements. One in particular that jumps out at me, what we do in healthcare intersects with people's lives in deeply personal ways. It's hard to even fathom just how personal this is and how personalized this needs to be. And representation matters. You can't possibly get that right if there's not representation through the design, through the development, through the delivery. And I think continuing to give voice to that and make commitments to ensuring that we improve and manage representation more effectively than we ever have before is absolutely part of the way forward. And it can't be part-time. I love that. I'm gonna use that if you don't mind. It can't be part-time. It's got to be part of everything.
From him.
Yeah.
PG.
Yeah. It's got to be part of everything we do and in every way we do it. And so in that vein, to ensure our dialogue continues to drive momentum, not just in our individual full-time efforts, but in our shared actions, I'd love to hear from each of the panelists on how we can better work together to collectively align our efforts with the needs and priorities of the communities we serve, to be as efficient as possible and avoid operating in fragmented silos. So this is really open for the group. Would love to hear from each of you and whoever would like to get us started.
I'm happy to jump in. I've hinted at, well, I've actually said it out loud, that we have to sustain our whole of community response. I've always long said my mantra is health equity is everybody's work. And I mean that. I mean that wholeheartedly, and I mean everybody. Even the people that we serve have a role to play. So the second of that, we have 6 recommendations that came out of the summit. The second one is promote a culture of wellness and DC hope. This comes from during the pandemic: health, opportunity, prosperity, and equity. We can't let go of that. All of those things have to come together. We have to repair the past to transform the future. That means we can't go forward in an ahistorical kind of way as if we don't know what has created some of the past injustices. And Amelia gave some great current inequities that persist in our supposedly data-driven practice that we have to change. We have to prioritize community engaged practice. That means that we're not going to sit in a room and decide what the community wants and give them what we think they want and think they need. We need to go ask them and engage them all the time, not just part-time, so all the time. And then we have to leverage the policy and practice momentum that we've learned from the pandemic. And then finally, anchor our collaborative actions for impact. So we need to all do the best work that we are best positioned to do, but we need to know what the other person is doing so that we're not duplicating, we're not working against each other, and we're all rolling in the same direction. And that's the overarching idea of why we want to literally take a health in all policies approach to our Healthy DC 2030 process, because that's going to create our 10-year momentum as to where we're going to go going forward. And so we're going to engage, sorry about that, all of our partners across the board on how that works. And it needs to be sustained, ongoing, not come back in 5 years when we're ready to do a new strategic plan. It needs to be ongoing with our partners, both in healthcare, across public health, the anchor institutions in our city, the chamber, small businesses, large businesses, all of the above.
And
Thanks, Dr. Arno. Mila, your collaboration is at the heart of what you do. What can we be doing better together?
thank you. And I was just going to piggyback on what Dr. Arno said, give you an example of how we practice what just laid out. So from day one, we developed our policies. So we like to bring together people, different stakeholders who most of the time don't agree with each other on policy outcomes. When one opposes another one, supports particular legislative initiatives, for example. So for this journey, we wanted to bring as many experts as possible. So when we set up our social justice working group and disparities working group, we had Dr. Arno as one of our experts. We had folks from DC's Medicaid. We had your team and all of our health plan partners. We had Jackie and her team. We had physician groups. We had employers and individuals who actually get their health insurance through DC HealthLink. And we all rolled up our sleeves to figure out, well, what are the problems that we can actually fix, and let's come up with consensus-based solutions. And so that's what we did. And now we were, in hindsight, we were missing the large employer community in the first round. So as we are going to re-engage our social justice and health disparities working group, we're going to be thinking even broader. Who did we miss the first time? Who can we bring in, and how can we make our policy deliberative process work even better?
Jackie?
Well, I think, it's pretty much been said. I think you guys really touched upon everything that I would have offered. I think the one thing that I would add is when I think about the fragmentation and the silos, I also feel like we need to make sure that there's awareness of what's already been done, what's worked, what those best practices look like, and what didn't work, so that we can avoid finding ourselves in someone saying, oh, didn't we do that 5 years ago? So it is what's, the live action of avoiding the fragmentation and the silos. But as we move forward, years down the road, how are we making sure that inventory and awareness of what we've already done, what worked and what didn't, but also that the consumer is very much aware of how those activities impacted their lives. So I agree both with Mila and Annetta in terms of the way to align and ensure that we don't have that fragmentation. But moving forward, I often find ourselves kind of not only reinventing the wheel, but reinvesting in the wheel. So those type of activities on top of what was already said, I think is what will really help us moving forward.
It's a great reminder, Jackie, and Chairman Gray, I feel like it's only fitting to give you the last word on building alliances to drive progress. What would you like to see us do better together?
Well, Brian, I want to see us, take advantage of the opportunities that are right in the midst. I look at working with Wayne Turnage, for example, and what he has done with healthcare finances. It's almost unbelievable what he's been able to accomplish. It's absolutely a prime primer, if you will, and how to actually develop relationships that can work across the government. We've seen it in so many instances with healthcare finance as an example. And that to me is just an example of the kind of collaboration that can benefit all of us in the work that we do every day. You know, again, I want to make sure we don't forget the folks that we're working with, you know, in this panel today. Angela, the people who work with the chamber, make sure that we continue to work with you and others, because those are such important relationships that we need to continue to develop and build upon as we go forward. So, Brian, I think if we continue to build on the relationships that we have before us, we will continue to be better for it. I look at the healthcare system that we're trying to build. We've got lots of work to do there and lots of opportunities that are available to us. So I hope that you and others will be helpful to us in making these opportunities available where they just don't exist for some people.
Thanks, Council Member. And it's been an honor to be with this group today. And I think even more importantly, I just want to say thank you for your efforts individually and collectively to lead us forward outside of these panel discussions each and every day. So thank you so much for your time today. And Angela, we'll turn it back to your team.